about EKGs. EKGs is a enormous topic, and it has like infinite levels of minutia nuance. So it's sometimes hard to know where to draw the line. But I'm trying to keep this to things we're going to see and things that are actionable for us, like things you're going to actually get called about, and that it would be helpful to be able to identify. All right. So some objectives for us today. We're going to review the anatomy of an EKG, kind of go back to the basics there, talk a little bit about vectors. We're going to go through the steps that you should always use when reading any EKG, according to me. Some narrow complex tachycardias, wide complex tachycardias, few blocks, and the piece de resistance, ischemia. All right. I have no disclosures. All right, starting off with the basics. So I know people probably have a very wide range of comfort levels with kind of the nuts and bolts of an EKG. First thing, before we start talking about other things, is kind of how do we actually measure things on an EKG? So the EKG strip, is divided by these nice this nice grid. You've got small boxes and large boxes. And sometimes we will refer to these boxes by millimeters, and sometimes we're going to refer to these boxes in terms of length of time. So all of these things are based on the paper speed of 25 millimeters per second. This is standard. You will basically never have to know or think about what speed the paper is going at, but just know that if for some reason somebody tells you that the paper speed is 10 and not 25, none of these things will apply because it'll have to be calibrated differently. But you shouldn't have to know that. So one small box is gonna be either 1 millimeter or 40 milliseconds. One large box, 5 millimeters or 20 milliseconds. When we talk about things like ST elevation, T-wave inversions, things like that, a lot of times we're talking about those in terms of millimeters. That's where our criteria come from. When we talk about intervals and things like that, we're usually referring to them in milliseconds. So we're going to be talking a lot about rate in here. Every single one of our EKGs, we're going to want to know what the rate is. So a couple quick ways to calculate your rate. First of all, you can look at how many large boxes are in between the R waves. So take the number 300 and divide it by the number of large boxes between the R waves. If there's one box, that means that the rate is 300 beats per minute. There's two boxes, the rate is 150 beats per minute, and so on. And you can apply that to P waves as well to get atrial rates. Let's see, I don't think y'all can see. Okay, so the other thing, if it's an irregular rhythm, so like where the R to R interval is changing with every QRS, you can just count the number of QRS complexes on the piece of paper and multiply that by 6, and that'll roughly give you the ventricular rate. Or you can do the same thing with the P waves. Any questions about that before I move on? All right. Quick reminder of what are the names of our waves. So P wave, what's the P wave? What's happening at the P wave?
They're contracting, they're depolarizing.
So the P wave is the atrial depolarization. So the contraction actually comes a little bit after. So you have the electrical signal go through it, and then the contraction happens a little bit after. The Q wave, not always present, but it's a downward deflection at the beginning of the R wave, and then followed by the S wave. So what's happening during the QRS? Ventricular depolarization, right? So you have the going down the His-Purkinje system, the bundle of His, and then back up. That's why you have that negative deflection, because you're going the opposite direction. And then the T wave, finally.
Repolarization.
Yeah, repolarization of the ventricle. Got it. All Just some normal values real quick. So the PR interval, we're going to be talking about that a little bit. Normal is less than 200 milliseconds. And for QRS interval, normal is going to be less than 120 milliseconds. So, and the QRS, that's from the beginning of the Q wave to the end of the S wave, where the S wave levels out. That is, all right. So now we're going to talk about some more intervals. All right, first thing, right there, we're already seeing that the formatting shifted a little bit with the change in PowerPoint. All right, so R to R interval, that's our ventricular rate. Measure between the peaks. We got our P to P interval, that's our atrial rate. QT interval, that's the beginning of the depolarization of the ventricle all the way to the end of repolarization of the ventricle. What is this? This is very important, but not talked about very much. TP interval. So that's the TP interval. And why is the TP interval so crucially important?
Did you get like a, well, that's not really accurate, but I would.
So it's a reference point. So that's going to be our isoelectric baseline. Okay. So whenever we talk about ST elevation, ST depression, PR depression, PR elevation, we have that's relative to something. And what that's relative to is the TP interval. So whenever you're trying to decide if you think something is elevated or depressed, look at the TP interval and go from there. So very important interval to be familiar with. All right, quick bit about QT versus QTC. So the QT interval, we talk about it a lot, and usually it doesn't amount to much, but the QT interval is going to be dependent on the heart rate. So the faster your heart rate, the smaller that interval gets, the slower your heart rate, the longer it gets. So we want to have a way to compare the QT between different EKGs on the same patient with different heart rates. So we have some math that we do to it. That's called the QTC. So you'll see on your EKGs, you'll see a QT and next to it a QTC. You really want to look at the QTC because the QTC is going to be more reliable from EKG to EKG when their heart rate is changing. So the QTC is based on a normal or baseline heart rate of 60. So if your heart rate is 60 beats per minute, the QT is going to equal the QTC. Now, there are going to be situations where you should calculate the QTC yourself. We'll talk about that a little bit, but go into MD Calc. You're going to have like 7 options for formulas for calculating the QTC. Choose Bazette. And the reason is that's what my wife told me you should choose. So that's good enough for me. When in doubt, calculate QTC by hand. It's very easy to do. You just measure the number of small boxes and plug it into the Bazette formula. But if it really matters, do not trust the EKG's measurement of your QT or QTC. They can be very off. And then we actually got an email about that recently about you may have seen that our EKG machines, which we've known for years are bad at this, but we recently officially said that. All right, cardiac axis. So this is pretty good schematic of the axis. So imagine placing this just directly on the center of your patient's chest. Okay, so the middle of this axis can be right there on the sternum, and that's your orientation. All right, so you have here some of your leads that you're probably familiar with seeing on the EKG. So 1, 2, and 3 are actual leads, and then the V's, those stand for virtual. So those don't correspond to an actual sticker on the patient's chest. They're calculated from the vectors that you get from these other real leads. So up here we have the sinus node. Yeah, sorry guys, this is an older version of PowerPoint than the one I use, so things are going to be a little squirrely. So you have the sinus node up here. That's where your atria are. You can picture your heart sitting in space. And down here is the ventricular apex. So the overall electrical current goes from the sinus node to the apex, and see it passes through what we call the normal QRS axis here, okay? And this is going to be important for a few things later. But basically, if you want to quickly know how to tell if you have a left or right axis deviation, if it's up in leads 1, 2, and 3, that's normal axis. If it's up in lead 1 and down in lead 2, that means that that means that the vector is below this middle line, but it's pointing away from lead 2. So that means it's at least greater than 90 degrees away from lead 2, which puts you somewhere over here. And same thing with right axis deviation, with left axis deviation, it puts you over here, and the opposite with right axis. It's not something that you like need to memorize, and it's not something that's going to be terribly actionable at the bedside, but it's still good to kind of understand. Any questions about axis real quick? We're going to come back to it a couple of times with some more real-time stuff. All right, so reading the EKG. So there are 4 questions that you need to be able to answer about every EKG that you read. And you should be able to answer these questions, or at least the first 3, fairly quickly. And these are things that will allow you to accurately describe your EKG to another person. And if you say these things, then they'll be able to pretty quickly narrow their differential for what might be going on. First of all, calculate the rate. Second, is it regular or irregular? Is the QRS complex wide or narrow, so greater than or less than 120 milliseconds, or 3 boxes? And then, is it sinus? So is it sinus is sometimes a very easy question to answer and sometimes a very hard question to answer, but a very important question every time you're reading EKG. So, and the last definition is, what is normal sinus rhythm? So normal heart rate, 60 to 100. You need to have a P wave before every QRS and a QRS after every P wave. You need to have a narrow QRS, and you need to have a normal P wave axis. So should have had this in there, but so a normal P wave axis means that you're going to be up in lead V1 and down in lead V2. And that basically puts you along this arrow here. If it doesn't fall along this, especially if it goes the opposite direction, that tells you that the electrical impulse is starting somewhere that it's not supposed to, someplace away from the sinus node. And that should call into question whether what you're looking at is sinus. All right, so our first EKG. Does that look good? All right. Who wants to read the EKG? Treva, calling on you. Start with the rate.
Well, I can barely see it, but I think I see 3 big boxes. So what's that divided by? Was 300 or 150? 300, 150, and then around 75 beats per minute. I see P waves after every QRS and 1 before every QRS. What was my other question? Sinus, and then.
So is it right? Do you think it's regular or irregular? Okay.
And this looks like it's normal sinus rhythm.
All right, love it. Yeah, so okay. A lot of surprises here. So the rate's around 95. It's like a little less than 3 large boxes. So fits for normal so far. Yeah, it's regular. There's a couple ways you can, measure that. You can take a piece of paper. If you've got a paper EKG, take a piece of paper, mark the edge of it with a couple of the R waves, and then see if it marches out. But also, have any of y'all used the calipers in? Y'all know about the calipers? Okay, yeah, use your calipers. They're great. All right, narrow QRS. Yeah, it's a little hard to see the small boxes, but it looks pretty narrow. And then here's our P waves. So they're down in AVR and they're up in lead 2. That tells you that the axis of the P waves is correct. And because there's no hard rules in electrophysiology, you can never say that something is definitely sinus unless you do an EP study according to the electrophysiologist. But we're pretty damn sure that that is a normal P wave axis, and this is going to be normal sinus rhythm. So that is all right. We're going to talk first about some narrow complex tachycardia. Is probably the most common thing that we get called about in the hospital. So these are going to be your tachycardias with a QRS less than 120. And it's narrow complex because this is being conducted through the His-Purkinje system and not myocyte to myocyte. And generally, the impulse is happening above the AV node. So differential, I accidentally gave you AFib. What else might be a narrow complex tachycardia? Got flutter. Got heard SVT. All right. Usually AV nodal reentrant tachycardia. That means that the impulse is actually coming from within the AV node itself. What's the most common narrow complex tachycardia? Sinus tachycardia. And then there's a couple of rare ones, junctional tachycardia and atrial tachycardia. If you're talking to a first-year cardiology fellow, they're going to always tell you that it's atrial tachycardia. It's never atrial tachycardia. It's actually really rare, but it's fun to try to diagnose. All right. Hopefully this doesn't happen every time. Surprise, it's sinus tachycardia. So we got a P wave before every QRS, QRS after every P wave. And heart rate's about 120. All right, hopefully this next one works. Okay, good. All right. So I need a volunteer. Gonna need a lot of volunteers today. Tony,
I
Wanna
did
take-
it, you can do it.
you're gonna do great.
Follow me, follow me.
Just tell me what you see. All right, what's the rate? Is it fast or slow, do you think? So it looks like probably about, it's gonna be flutter. You got it. So this is flutter, and the thing about it is it does, like if you look in V1, it looks like this is a P wave. But it's a very sharp P wave, but you also notice that the T wave is like weirdly sharp. Whenever you see a T wave that's like has a point to it or something like that, you should be suspicious that there's something buried in that T wave. And if you look down here at lead 2, you can really see that this baseline just goes up and down, and there's no isoelectric point here. And those are your flutter waves. So this is 2-to-1 conduction. And what that means is that you have 2 flutter waves for every 1 QRS. You can have 3 flutter waves for every QRS, 3-to-1, 4-to-1. And also you can have a variable block. So someone who's on like a beta blocker or something that blocks the AV node, sometimes they might go from 3-to-1 to 2-to-1 to 4-to-1. But you'll still always see that nice sawtooth pattern on the bottom. And what's really important for identifying atrial flutter is that your atrial rate should be around 300. So if you're really not sure, you can march out those waves and you'll see that they like one large box between those, right? So that tells you that atrial rate is right at about 300, which is pretty consistent across atrial flutter. It's going to vary a little bit, but it's going to be pretty close to that. So if it's like way less than that, you should be suspicious that it's not flutter, or if it's way faster, or if it changes. Here, it's going to be consistent. So if it looks like it's like a wildly changing atrial rate, it's probably not. You can't really read this, but what it says here is if it's irregular atrial rate, it's probably AFib. All right.
Go for it, man. So I want to try to do the rate first. I'm just gonna ballpark that one around like 120 without trying to do the math. And then it looks like it's going off of just that isoelectric line or kind of like that.
But hard to say that really, like there's some places you might be able to make an argument that there's something that looks like a P wave, but a lot of places not, right? Yeah. So it's irregular and I can't really find a P wave. So pretty much always going to be AFib. So yeah, heart rate of 156. I calculated that by doing the counting and multiplying by 6 method. So this is irregularly irregular, no discernible P wave. That's going to be AFib. All right.
Well, I have a question.
Yeah.
On the P or the AFib. So if you occasionally have a P wave, would you still call it AFib?
Yeah, I would. I mean, because you can still have some breakthrough like sinus beats. Because so the thing is with AFib and aflutter with both, the sinus node is it's being activated. It's just that it's overshadowed by this overwhelming ectopic electrical activity. So yeah, you can have moments when you get a sinus beat. So that having something that looks like if you look across all the leads in that one moment in time and it looks like a sinus beat, that doesn't mean that the rest of it's not AFib. It means you might have just gotten a sinus beat through. Because yeah, all of these, the sinus node is still usually still going. All right. CT. Now, a lot of times it can be hard to tell the difference between like a AVNRT and atrial flutter. The way you can tell though is if you give them atropine and it slows their heart rate down. If it's flutter, then when you slow down the heart rate, you'll see the flutter waves. And then you'll say, oh, there it is. Or if it's actually SVT, then you'll just fix it and it'll be clearly sinus rhythm again. So that's kind of how you tell. That's why if it looks like SVT and you're not really sure, give adenosine. It's never going to be the wrong answer. And it's either going to fix the SVT or it's going to tell you that it's something else. John forgot what adenosine is. You can Google it, John.
I think you said atropine the first time.
What did I say? Oh, adenosine.
Yeah, you said atropine briefly. I was like, wait a second. Make sure I'm not losing my mind.
Look at atropine. That's not going to help you. That's always the wrong answer in this case. Sorry, that's categorically always the wrong answer if it's this rhythm. Don't give them
Did
atropine.
you ever give metoprolol before doing adenosine?
It's not
Situations like this. where
if
you're
there's-
trying to slow the rate to see what it is.
if their heart rate's 210 and you have access to adenosine, I would always do adenosine. But metoprolol, if like IV metoprolol is not going to be the wrong answer, like it might help. Like adenosine is going to be much more effective. The risk is extremely low of having a complication as long as, you put the pads on them. I've given adenosine many, many times and I've never had to use the pads that were on the patient. And I don't know anybody who has, but yeah, so adenosine should always be your first choice, but metoprolol might work and I've done that and it has worked. All right. A little bit about bundle branch blocks. We see that a lot too. So that's failure to conduct through either the right or left bundles. Usually not both. If we're not conducting through either, we're probably talking about a totally ventricular escape rhythm at that point. All right, so generally these are going to be wide QRSs. So knocking out either the right or left bundles. All right. So you have probably kind of a 50-50 shot based on what I just said. All right, so we got one vote for right bundle branch. Anybody want to challenge him? All right, so we got a predominantly positive or up deflection in lead V1 and a deep slurred S wave in lead 1, and it's wide. So, and it's regular. I also am seeing a P wave before every QRS and QRS after every P wave, right? So this is going to be a right bundle branch block. They're pretty consistent. They're going to look a little different from, case to case, but there are some things that are pretty well conserved. You have what's called an RSR prime in the precordial leads. So V1, V2, V3, V4, V5, V6. So you see how you see a little upward deflection here, and then an S wave, and then a big second upward deflection. That second one is called the R prime. It's all part of the QRS complex, but that's very classically consistent with right bundle branch block. And then you're usually going to see this slurred S wave in lead 1 as well. And so if you have all those three things, you can be pretty confident that it's a right bundle branch block. They're pretty benign. They're pretty common. Doesn't usually mean you have to do anything differently. All right. And I think that by you know, process of exclusion. Yeah, so this is gonna be left bundle branch. Again, it's gonna be wide complex. And it's gonna be predominantly negative deflection in V1, really in all of your precordial leads, but especially V1. Something that, you know, especially is on our minds when we're admitting people is, are they having a heart attack? So it's normal to see ST elevation in a left bundle branch block as long as it is discordant with the R wave. So you want to see the ST change go the opposite direction of your R wave. If instead that ST segment was down here, if it was concordant and they're having chest pain, then you should be worried. That is something that can be consistent with ischemia. But if it's discordant, it's normal and basically never associated with ischemia. Questions about that? All right. Few wide complex tachycardias. So wide complex tachycardias, this is when, similar with the bundle branch block, we're conducting the signal from cell to cell, myocyte to myocyte, so in the muscle, instead of through that nice His-Purkinje system, which is the wiring of the heart. So differential is going to be ventricular tachycardia versus one of your other supraventricular tachycardias that we mentioned earlier, plus a bundle branch block. So that's what aberrant conduction means, is usually a bundle branch block. Sometimes those can appear only when the heart rate goes fast, and then when the heart rate slows down, the bundle branch block goes away, but they can look similar. However, 80% of wide complex tachycardia in just the general population is going to be VT. So you see wide complex tachycardia 8 out of 10 times, if you guess it's VT, you're just going to be right. If they have coronary artery disease, which most of our, we don't see that many people with coronary artery disease. 90% chance if they have wide complex tachycardia, it's VT. So, you should think a little bit about wide complex tachycardia, but you're almost always going to be right if you think that it's VT. VT can be monomorphic or polymorphic, and we'll see what that means right now. All right. So don't have to go through, I won't make y'all read this one, but so this is going to be VT. So there's a lot of criteria for diagnosing VT, which is like an entirely different lecture. What I wanted to focus on was the fact that it's usually VT, but there are a couple of things that can be hints. So yeah, this is regular. It's regular, which is important for VT. Wide complex. If it's irregular, that's unlikely to be VT. That's probably going to be one of your other SVTs. A lot of times it's AFib plus a left bundle branch block. And going back to our axis, so we're up in AVR here. Up in AVR means that the axis is going 180 degrees the opposite direction of normal. That's what we call a northwest axis. If you think back to the that axis diagram. So if you, one sheet is if you look at AVR first and you see that it's up, it's VT, pretty much every time. Something that can be really hard to spot is if there's P waves that are just, you'll see sort of irregularities sometimes in like right there, that might be a P wave. If you see discordance between these little P waves and the QRS complexes, that's also a very strong indicator of VT, but they're really hard to spot, and a lot of times you just can't find them. So it's not a real hard and fast rule. So reminder of the axis. So if it's positive in AVR, that means we're going, normally we're going sinus node up here to apex down here. Now we're going the opposite direction. So pretty much no way that that is originating from the sinus node. All right. This is, I'll give you a clinical scenario. This is a very good representation of a patient I took care of in the CCU. So this patient we were giving dofetilide, which is a QT prolonging agent. And you have to measure the QT interval very frequently. And you should measure it by hand, which we learned the hard way. Because the machine was telling us that the QTC was around 450 and it was actually around 600. So this patient did this, and we shocked him, and then he was better. But notice we have the rhythm over here, and then we have the rhythm over here. Does this pattern ring any bells? So it looks like this wide complex, but the complexes are changing in amplitude. They're getting smaller, getting larger, getting smaller, getting larger. Got to vote for.
We're all
Pretty familiar with torsades. Okay, yeah. So yeah, this is torsades, but we start off not in torsades. And so this is a really good example of why the QTC matters. So these are our sinus beats over here in blue, and these are PVCs. So if the QTC is too long, it creates this opportunity to have a ectopic beat, a PVC, occur while the rest of the ventricle is trying to depolarize. And if that happens, it can create a reentrant circuit and cause torsades. So that's how torsades actually happens. Try to bring this down. Yeah, torsades is an example of a polymorphic ventricular tachycardia. Not all polymorphic VT is torsades, but all torsades is polymorphic VT. In order to actually diagnose someone with torsades, you have to have demonstrated a prolonged QT interval before that. Just a pearl about torsades. So if you're not sure, you can call it polymorphic VT and you'll be right, but torsades, you may get pushback from the cards about your definition. All right, so AV blocks, something we see pretty frequently, especially getting called from the telemetry office about. So first degree blocks, just a PR interval greater than 200 milliseconds. It doesn't mean anything. It is clinically of no consequence ever. You can see it when they're on AV nodal blocking agents, calcium channel blockers, beta blockers. It's not a predictor of any badness. It's just something that we see. So when somebody tells you that somebody has first degree block, you say thank you, and you move on. Second degree blocks, a little different. Type 1, we have a PR interval that is going to progressively get longer and longer until suddenly we have a non-conducted P wave, and then we start the process over again. And then we have type 2, which is where we have a fixed interval with unpredictably dropped beats. And then we have third degree, which is complete heart block, no association between P waves and QRS. So none of the P waves are actually being conducted, and usually the ventricle is doing its own thing. So this box, basically type 2 and below, these are class 1 indications for a pacemaker. Winky Bach, they will rarely put a pacemaker in unless they're symptomatic, and you can definitively say that it is not medication induced and that their symptoms are definitely from the Winky Bach. So pretty rare that they'll do a pacemaker for Winky Bach, but they'll pretty much always do one for type 2 or third degree. And it doesn't even matter if you have an explanation for the type 2 or the third degree. If they have it, then they're getting a pacemaker. All right. Cam, you want to read this one?
Yeah. So it looks like the PR interval is getting longer and longer. And then it's dropping.
Mm-hmm.
So Winky Bach.
All right. Yep. So there's our non-conducted P wave. So this is, yeah, Mobitz 1 or Winky Bach. This is 5-to-1 conduction. There are 5 P waves for every dropped beat. Now, if you're looking at something, sometimes it's subtle. Sometimes when you look at the lengthening, like here, it's pretty convincing that it's lengthening. Sometimes the lengthening is very subtle. So what you always want to do is look at the last conducted beat before the drop, and then the first conducted beat after the drop. That's where you're going to see the biggest difference in the PR intervals. And give you the best chance of being able to say if you think it's type 1 or type 2. Sometimes you just can't tell, but a lot of times you can. And especially on a 12 lead, you might have trouble. So that's when you go to the telemetry and you can look at a much longer segment, and then you might be able to capture it. Oh, this one did not come out very clear. So this one's a little sneaky. Do I have someone on Zoom?
Kind of 3-to-1, tap 1, 4-to-1, tap 1. It almost looks like 30 degree, but they're regular enough as far as when the beat gets dropped, that it looks more like type 2.
So the PR interval looks pretty consistent, right? So I sent this PowerPoint to my wife shortly before this, and she actually disagreed with me on my diagnosis, but said it didn't really matter. So so this one, there's our conducted P wave. And like I said earlier, if you see a T wave that looks suspiciously pointy, you should be suspicious that there might be a P wave in there. And in this case, there is, and it marches out perfectly. So I was calling this 4-to-1 Mobitz 2 because of the fixed PR interval. Atrial rate is around 140, but the ventricular rate is only around 36. So one of the things that you might look at this and think is this flutter? And that's why, remember, it's important to know the normal atrial rate in flutter is 300. It's not going to be 140. That's way too slow. So you calculate that atrial rate and you say that does not fit. Now, what my wife pointed out was this could be complete heart block also, and you can have a phenomenon where the QRS
They're just in harmony.
they're random, but they just happen to be in harmony, and you capture a 12 lead and you can't tell. But that's again why we put people on telemetry, because you can look at a really long strip and you can start to see those subtle changes of dissociation. But we'll just say that I'm right on this one. All right, this is a good one. And this is one that's also not uncommon. And just in the interest of time, I'm going to breeze through this one. So, all right, we've got a non-conducted P wave. We got a conducted P wave. We got a non-conducted P wave. We got a conducted P wave all the way across. So is it type 1 or type 2? Because we can't see that there's lengthening of the PR interval. Yeah, so there's no way to tell. You have to do an EP study. So if it's 2-to-1 block, you just say it's 2-to-1 block. You can call cardiology and they can figure it out. But based on this EKG, there's nothing you can do to differentiate between the two if it's 2-to-1 block. And then one that is a little less controversial. So clearly very slow, right? Also notably, the QRS is long. So wide QRS tells you maybe we're not conducting through the His-Purkinje system, and maybe our ventricle is actually doing the pacing in this case. So looking at so there's again a hidden P wave kind of there at the end of the T wave. But you look at the PR interval, it looks like it's lengthening. But since you have so many unconducted P waves, the fact that it's lengthening means that it's more likely just AV dissociation than it wouldn't be a type 1 because there's so many unconducted beats. So this is going to be 3rd degree block. So this is a ventricular escape rhythm. And when the ventricle is not getting any signals from the atrium, it has a built-in mechanism to take over pacing. And its natural pacing is going to be around 30 beats per minute. So that's also a clue that this is complete heart block. Class 1 indication for pacemaker. All right. Now, the thing everybody really wanted to hear about was ischemia. So first thing is, remember that ischemia and ACS, this is a clinical diagnosis. So the EKG is a tool, but there are going to be a lot of situations where the EKG is not going to definitively tell you one way or the other what's going on. You can have a normal looking EKG and be having ACS. All right. Have y'all learned this before, the territories? So this is going to be really important when you are making a decision about whether you think that ST changes or T wave changes are actually significant for ischemia. And that's because they need to be, you need to have at least two in contiguous zones. So this is a map showing us basically the blood flow territory, as it corresponds to the actual EKG. All right. So, lead 1 and AVL, those are your high laterals. 2-3 AVF is inferior. V1, V2 anterior-septal, V3 and V4 is anterior-apical, and then V5, V6 anterior-lateral. All right. So, clinical scenario. Got a 58-year-old man presenting with chest pain for 2 hours. He's relieved by sublingual nitro at home. He comes in, he's still having chest pain. His initial troponin is negative. So a month ago, this was his EKG in clinic. So this is not right now, but this is what his EKG looked like a month ago. So pretty normal. And then he comes into the ER, and this is the first EKG we get. So what's different? Yeah, definitely some T-wave inversions in 2-3 AVF, right? And there's some flattening in sort of the lateral and apical. And what else do you notice that's new? Yeah, so he's having some PVCs. So yeah, so there's our T-wave inversions that are new. 2-3 AVF are all in our inferior blood flow area. So those are contiguous. And so notably though, 1 and 2 are not contiguous. Those are separate areas. So 1 is a high lateral lead and 2 is an inferior lead. So the fact that you would expect those to be different. All right, and then we have PVCs. So this guy's having chest pain, and he has new deep T-wave inversions, which is very concerning. So this is sinus rhythm, P-wave, and with PVCs. So these T-wave inversions are greater than 1 millimeter within contiguous leads. Don't see any T-wave changes, but we do see PVCs. Someone having new PVCs in the setting of chest pain, very concerning for ischemia also, and should raise your alarms. So this guy got a left heart cath. He had diffuse disease, and he ultimately got a cabbage. But he was not having a type 1 event because his troponin actually remained negative. Most people don't thread the needle like that. And that's why we have high sensitivity troponins. All right, so a little bit about ischemia. So first of all, the T waves greater than 1 millimeter in at least 2 contiguous leads that are new. Or if their baseline EKG has inverted T waves and suddenly those T waves are upright, that's also concerning. That can be just as much a sign of new ischemia. And then ST depressions, similar. You want to have greater than or equal to 2 contiguous leads, at least 0.5 millimeters of depression. And the deeper the depressions, the worse the outcome for the patient. So greater than 3 milliliters of ST depression is if it has positive troponin, that's like a 30% mortality rate at 90 days. So it's interesting. All right. What do we see on this one? Oh, sorry.
B2, no, that's not your fault. It's probably my eyes. B2, B3. Maybe.
B2, B3 are sus. AVF also. Any others? Yeah,
And B1 looks like it.
it's remarkably hard to find like really good quality scans of EKGs like on the internet. Yeah, so looking at 2, 3. So yeah, 2, 3, and there should be a circle in AVF. But yeah, 2-3 and AVF, we see, it looks like a little bit of ST elevation, and for what it's worth, they're all at least a millimeter. And then, like you pointed out, V2 and V3 are depressed. So what's happening in V2 and V3 we call reciprocal changes.
That's like a posterior.
So yeah, in this case, it's going to be, so he has sinus bradycardia with ST elevations in leads 2-3 and AVF with reciprocal depressions in the anterior leads. So if you have ST elevation in the inferior leads, you expect to see sometimes reciprocal ST depression in the anterior leads and vice versa. If you have an anterior STEMI, a lot of times you'll see reciprocal depressions in the inferior leads, but that's not a requirement for something to be called a STEMI. However, it does support that diagnosis. So yeah, this was an inferior STEMI. And something that's also significant is the heart rate is very slow. That's because the RCA supplies the AV node a lot of times. So it's common for people who have an inferior infarct to hit their AV node, and they can have either sinus bradycardia or complete heart block or high grade blocks associated with them. That's one of the scary things about inferior. So it's going to be uncommon that we're going to have to be using STEMI criteria. STEMIs are actually not that common, and they're also pretty rare to happen on a patient that's already admitted to the hospital. But the mortality rate associated with STEMIs, no matter, even if they get revascularized, is still pretty high. So it's, very important to catch. So for the anterior leads, so like the V2 through V3, has to be greater than 2.5 millimeters of elevation. And for women, 1.5. And then in any of your other leads, so for example, your inferior leads, it only has to be 1 millimeter of ST elevation. So like in our previous one, really only about 1 millimeter, maybe 2 millimeters in lead 3, but that's enough to call it ST elevation and meet STEMI criteria. Of note, this guy's having chest pain. If they're chest pain free and they have no troponins and they have those findings, very unlikely that it's ACS, but still take it seriously. Also, left bundle branch block. You may have heard this. If you have somebody coming in with chest pain, if they have otherwise a clinical scenario that fits with ACS, and they have either a known new left bundle branch block, or if they don't have old EKGs and they just have a left bundle branch block, that person should probably go to the cath lab. Because in left bundle branch block, there's what's called the Scarbosa criteria, but it's much less sensitive and specific. And so it's harder to rule out ischemia with a left bundle branch block. So this is our last EKG for the day. And it's a curveball.
B-Bob 6.
For a lateral.
So we got pretty diffuse ST elevations. No depressions. What about lead 1? Do you see some elevation in lead 1 too?
Pericarditis.
What do you think about the PR interval? So look at your TP intervals. See if anything else looks off. You can see it pretty well in, you can see it in lead 2 and lead 1 and like V6. It's always subtle, and then the same here, but you can see that you might be able to see the PR interval is a little bit below the TP. So we have diffuse ST elevation and diffuse PR depression in a patient who has chest pain that's relieved by sitting forward. Yeah, so also something that's fairly specific for pericarditis is if you have diffuse ST elevations, and more specifically, if you have ST elevation in lead 1 and 2, those are non-contiguous leads. And if it's in 1 and 2, it's almost always pericarditis. It's like a very specific finding. So yeah, sinus tachycardia, diffuse ST elevations, and PR depressions with no reciprocal ST depression. So yeah, this is going to be pericarditis. I have seen a lot of patients with pericarditis. I've never seen one that had the classic EKG findings. So These are not all that sensitive or specific, but they're neat. All right, and that's
So with the ST elevations, how
Mhm.
high is that one in league one? Is it? It doesn't
it's like a
look-
millimeter.
It is, okay.
Well, it's not even maybe that, because if you actually look at the TP interval, it's maybe like half a millimeter.
So that's what your mole's.
So it's pretty subtle. If you look at the PR interval, it looks like it's a whole millimeter, but if you look at the TP interval, it's probably more like half a millimeter. Yep. Well, that's all I've got. What questions can I answer about EKGs?
I love it. It's good, a really good review.
Very good.
Yeah.
All right.
You know, I actually have a question.
Yeah.
So I got a call one night on a cross-current patient, and it was actually Dr. I think one of the cardiologists, I can't think of his name. He's the one that reads all the EKGs.
Pog?
Pog, yes, thank you. He called about a patient, and of course, the machine was reading the QTC interval incorrectly, but he made a comment too about the magnesium level was extremely low, and that would affect the QTC interval as well too.
Sorry, I just got a page. I see that one more time.
Oh, that's right. No, he was just telling me how the QTC interval would also affect the PR interval, or I'm sorry, the QTC interval was affected by the low magnesium.
Yeah, so I don't know the physiologic mechanism. And I don't know how much low mag actually prolongs the QT interval, but giving magnesium is like our, if somebody has torsades, that's like
Yeah.
the first line. So yeah, I don't know if the data is actually that good on like correlating low mag with UTC. I've looked this up before, but that's why people in the CCU, everybody's like mag of 2 or greater. Yeah, I think it's more specifically with people with like really prolonged QT, that like low mag can maybe push them over the edge, but if like somebody otherwise has a normal QT, I don't think that a low mag usually like creates a problem. But yeah, like people who are at risk of going into torsades probably want to have a normal mag. Definitely got yelled at by cardiologists for that too. All right. Last time.
Thanks so much.
Thank you.